I thought I would just take us on a historical tour of how breast cancer is going from one size fits all to much more personalized care. And this is happening in all of oncology, but I think it's probably exemplified in breast cancer probably more than most cancers. And while we'll talk mainly about treatment of stage 4 today, it's still being applied in stage 3 and stage 2 as some of the others. And really, breast cancer was the first personalized care of targeted therapy when in the late 40s and early 50s, they would take women in horrible bone pain with metastatic breast cancer to the operating room, and they would take out their ovaries and would talk about, and as old as I am, this is still even before my time, they would talk about people wheeling back into the room after their surgery being pain-free for the first time in months. So they were lowering people's estrogen levels with the oophorectomy, and that was really one of the first targeted therapies that there was. From that evolved testing for estrogen and progesterone receptors. And in college, at the back of my endocrinology book, there was a brief explanation about hormone therapy for breast cancer. And at the time that I read at age 21, I didn't understand what progesterone was involved and what the progesterone receptor meant, but I felt sure in med school or residency or fellowship or training, I would understand progesterone receptors better. And after 50 years, I still don't, but it is better to be both estrogen and progesterone positive than just estrogen positive. And one of the 5 types of breast cancer that we break down is indeed a type of breast cancer that's estrogen positive and progesterone either low number or negative. And while they can still respond to hormone therapy, they don't respond as well as if you're strongly estrogen and progesterone positive. So what's called luminal A breast cancer is someone with a very high estrogen receptor, a high progesterone receptor, and a slow-growing tumor that responds well to anti-estrogen and doesn't respond very well to chemotherapy. So that in somebody, if they need preoperative therapy before breast surgery for stage 1, 2, or 3, people who are strongly luminal A breast cancers, we don't give them chemo because it doesn't work, so you give a preoperative anti-estrogen therapy. So estrogen, progesterone were really the main guiding therapies, and they're about 60% of breast cancer for a long time. And then in 1989, they discovered a protein on the surface of breast cells called HER2, which is an on-off switch. And in those people, the switch is turned into the on position. And when they then went back and looked at people who were HER2 in retrospect, it was felt to be a bad prognostic factor in that the people didn't do as well. But in 1999, they made an antibody to it called Herceptin. And for 20 years now, we've had multiple new drugs that I'll talk about in a few minutes for HER2 positive breast cancer. And HER2 positive breast cancer represents about 15% of breast cancer. Half of the HER2 positive breast cancers are estrogen positive and half are negative. So many of the studies we did in the 70s and 80s, all people with breast cancer were lumped together, estrogen positive, estrogen negative, HER2 positive, triple negatives. And therefore, sometimes the results didn't make much sense because you were putting apples, oranges, and pears in a bottle and then getting conflicting results. So we really now have gone to the point of view of people are in studies estrogen positive or triple negative, estrogen negative, progesterone negative, and HER2 negative, or HER2 positive. So we can limit our therapies and our approaches to those kinds of treatments. Then there was a group of people, and once HER2 came out, you could then have HER2 positive or HER2 negative. So then you really had people who were triple negative and certainly felt to be people who in the first 5 years after their diagnosis had a worse prognosis But if you survive without any relapse with triple negative after 5 years, your prognosis is actually better than being estrogen positive. There was then a group of people where they were estrogen positive, and we would give them therapy with an anti-estrogen, tamoxifen if you're premenopausal, or turn off the adrenal glands if you're postmenopausal with anastrozole and its cousins, and they still did not respond. So people began studying that and then realized that there's more than one pathway, that the estrogen is one on-off switch, but you can have other on-off switches that also control the growth of breast cancer. So we came up with these drugs called CDK4/6 inhibitors, palbociclib and ribociclib. They're pill form. And I don't know what to call them. They're really not chemo, but they're not anti-estrogen drugs either, but they block another pathway. So you use an anti-estrogen to block one pathway, and then the CDK4/6 to block another pathway. So that is a whole nother group of people who are estrogen positive, but being treated completely differently than they were years before. And then as we began to understand that some breast cancer is inherited, so people who are BRCA positive have that BRCA mutation. That mutation is a breakdown. We have a way to repair our DNA when it breaks, because every day all our DNAs are breaking every day, and the PARP, there's a PARP pathway that repairs broken DNA double-stranded. But if you have the BRCA gene, you can't repair those breaks, so you can get a break in your breast cancer cell. And why you get it in your breast cancer cell and not your liver cell, nobody knows, but you have a tendency to then develop a high risk of breast cancer. And now in people who are BRCA positive, there are drugs that interfere with another repair system. So if you can't repair your damage and you're on chemo, which breaks the DNA, and then you can't repair it with using a PARP inhibitor, then it's another way to treat breast cancer, but only for a very limited number of people who are BRCA positive and maybe one or two of the other inherited forms of therapy. But treating ovarian cancer and breast cancer with PARP inhibitors has certainly become a standard of care. And then more recently, we had, my screen's getting all that, good. There we again have another group of people who are estrogen positive, and if they have a mutation where something called PI3 kinase, again, another pathway, another highway, if that's operative, you can take a pill and block that. And so just within the last 2 years, 18 months maybe, if you do DNA testing on the breast cancer and you carry that mutation, then you can take a pill that will block that pathway, will turn off that on-off switch, and therefore can go. So estrogen positive people now have 5 or 6 different treatments that only work for estrogen positive and only work for some people who are estrogen positive. So another way of personalization. And now we come then to triple negative breast cancer, certainly the hardest group of people to treat because you don't have targets. You don't have the estrogen target, you don't have progesterone target, you don't have HER2 targets. So probably more research is being done in the field of triple negative breast cancer to find something to attack than probably any other cancer at all. And so when immune therapy has come into its own in the last 3 years, where we take medicines that turn on our own immune system, and we can talk about that in a second, they've tried it in estrogen positive and estrogen negative patients, and people who are triple negative will respond to immune therapy more than the other groups. Right now, it's still only at about 20 or 25%. But if you treat people with chemotherapy and immune therapy at the same time, then you certainly can get a longer and better response. Why is that? The more mutations, the more DNA breaks that you have, the more your cell starts to look foreign. And there are some tumors that have almost no DNA breaks. Leukemias and lymphomas often have only one or two DNA abnormalities, whereas melanoma with ionizing radiation from the sun will have 1,000. And so the more DNA breaks you have, the more likely immune therapy will recognize your tumor as formed and attack it. And so about 20 or 25% of women with triple negative breast cancer can be treated with both chemo and immune therapy and come out with better results. But there's certainly no doubt that breast cancer is not as responsive to immune therapy as many other kinds. Melanoma, head and neck cancers, even lung cancer and bladder cancers are all more responsive. So the triple negative area continues to be a challenge to try to find something that we can target so you hit the cancer cell and leave the good cells alone, because chemo alone has clear limitations both in terms of effectiveness and toxicities, obviously, and therefore trying to find something else to target is really one of the more important challenges that we have. The other area where targeted therapy is happening is the brain. If people have triple negative breast cancer or they have HER2 positive, those tumors tend to travel to the brain more than estrogen positive tumors. The brain is a kind of sanctuary. The chemo or the anti-estrogen doesn't get into the brain as well, and therefore one can be treating somebody with a HER2 positive tumor. The tumor shrinks elsewhere in the body, and then people have trouble in the brain. And in just the last 6 months, people who have HER2 positive cancer that have something in the brain, there's a pill out now called tucatinib that penetrates the brain and about half the time can shrink a brain spot, which is almost unheard of. We've never had anything that penetrates into the brain. There's something called a blood-brain barrier that keeps medicines out of the brain, and tucatinib can get in, and we're certainly starting to see people who don't have to take more radiation in the brain, because there are limits, and then can be instead treated with tucatinib. So that is certainly another targeted therapy that is able to target not a kind of breast cancer, but the location of the breast cancer. And that's probably happened in just the last 6 months. So for right now, I think that gives us a sense that we're continuing to target more and more subtypes of breast cancer. And so when a patient comes in and says, my next door neighbor is getting this, why aren't you treating me with that? People are beginning to understand that there are really 8 or 10 kinds of breast cancer, and that what works for one sometimes doesn't even potentially work for another one at all. In terms of under the microscope looking at breast cancer, 85% of breast cancer is infiltrating ductal cancer, which are just the ducts that connect the area where the milk is made in the lobule to the nipple. And so that's most of breast cancer, but 15% of the time, the tumor is in the lobule where the milk is made, and those are almost always estrogen positive, and they behave differently and are treated sometimes differently. For reasons it's not clear, if you have lobular breast cancer, it tends to metastasize to the inside of the abdomen, whereas regular breast cancer, ductal, does not do so at all. So again, it's one more example of the DNA abnormality that helps determine how we treat people. And so I think in the next 5 years, you're simply going to see more and more subdivisions of breast cancer as we understand more and more about it. We routinely take anybody with, say, lung cancer and do an extensive DNA analysis of the tumor, not the person's DNA, but the tumor's DNA, because you can't have cancer without a broken DNA. And we're beginning to understand more and more when we know what's broken, we can target it and sometimes shrink it much more effectively than if we're just hitting it with napalm by hitting it as if it's all the cancers are the same. So I think this will continue to be the trend, and that in the next 5 years, there will presumably be 10 or 15 different new treatments, particularly for triple negative, which is certainly in need of more help more quickly than any of the others. So having said that, I'll stop for a few minutes. And I always find that when people ask questions, we get into more impressive discussions, and we just keep talking about the data. So be happy to answer any questions if I said anything that might have triggered a concern or a question on anybody's part. If not, I'll do duck calls and stuff like that, which I'm not very good at. So
I don't have the little thing where I can type on my phone. I don't see it. And I don't have a question, but I want to thank you. I had triple negative breast cancer, stage 3B. It'll be 19 years ago on February 1st.
Wonderful. Well, wonderful. And I think a lot of people start out with the triple negative knowing that it has a somewhat worse prognosis, not as bad as some people think. But I'm amazed how many people and how many doctors don't seem to realize that after 5 years, the relapse rate of triple negative is very low, and that people, you'll always worry, but the degree of worry is really not justified after 5 years very much. And so what was a worse prognosis when they start their journey, within 5 years, they now have better prognoses than the people who are estrogen positive, who haven't gone the full course of their disease yet.
I had not heard that before either, so that was a big plus to me. Yes. Thank you.
Oh, you're welcome.
So all of the treatments that you talked about, are they all available to our patients?
Yes, everything that we covered today is all FDA approved, all insurance approved. Some of the treatments now you have to study the DNA to make sure they qualify for it. But if you have the right parameters, then they're covered completely. And I won't say it's a side effect, but as a result of this, we have to do a lot more biopsies than we used to. When somebody used to start out with cancer, they had cancer and we just saw the x-ray and said, well, you've relapsed. But now, are you relapsing with estrogen positive, with estrogen negative, with HER2 positive? Have you gone from HER2 positive to HER2 negative? So all those questions come up. And one of the more challenging things is that so much of breast cancer, especially if estrogen positive, is what we call bony or bony only often. So people have bone spots, but no other spots. Biopsying a bone can be done. You can usually get enough tissue to say, yeah, this is breast cancer, this is cancer, this looks like breast cancer, but it's very hard to do all the molecular DNA studies on the tissue because the bone has to be decalcified and worked on. So it's a problem sometimes when you can't get enough tissue, either because it's in the bone, or our perennial problem now is it takes only a very small amount of tissue to make the diagnosis of cancer. It takes 5 or 10%, 25% times the amount of tissue to be able to send it to the laboratories to do DNA testing. So nothing's worse than after the person's waited 2 weeks to get a biopsy, and then we wait a week for it to come back, then we wait for the DNA to come back. You then get to walk in the room and say, QNS, I hate it, quantity not sufficient, and you have to start the process again. So that's true not just of breast cancer, but of many cancers, lung cancer also. But it's a byproduct of needing more information and realizing that the tumor that you had 2.5 years ago may not be the same tumor as it is now. As if cancer is not hard enough to treat, they've taken several people and done biopsies of multiple tumors in the body. We don't do this routinely, but as an experimental study, and found that the tumors are cousins of each other. They're not even identical twins. So one now in immunotherapy and even some in chemotherapy and anti-estrogen therapy, 2 spots are shrinking while the third one is growing. And that's disconcerting to the person who has it and disconcerting to us too, because who are you playing against? Is it the Browns? Is it Buffalo? Is it Kansas City? Because you're sort of playing against all three at the same time.
Well, I think if it's that scenario, it's the Patriots.
Oh, come on. I did cancer training in college in Boston. So I'm
The Bears.
yeah. So yeah, Bears. Yeah. When I moved out here, I was from several places, but I realized that I thought it was impossible to do cancer and psychologically survive if you also tried to root for the Cubs or the Bears. So I've stayed away from that completely. Some other questions I'm happy to answer.
So I guess the most important question is, so as for people here, so who should we have be doing these biopsies for you to send off?
Yeah, I think
our breast surgeon, which they're busy.
Yeah. Well, most of these, I go to Macomb and Carthage 2 days a week because no one else wanted to drive that far 40 years ago, and still no one wants to. So I'm used to working at small hospitals, and I've got to tell you, I've been sending more and more people to Peoria for biopsy despite the effort, because it's technically challenging. You need to get more tissue. Most of the time, it isn't going to be a surgical open biopsy, which is usually, it can be done most of the time with a needle biopsy. So I think interventional radiology is what we use most of all. And that varies tremendously from some hospitals can be small and have a very good radiologist who does them well, and others where in Macomb don't transmit this, but the only few times they've done needle biopsies, it seems like they never get it. So I don't ever send anybody there. So, and it's not their fault. They just don't do enough. And if you do 100 a month, then you'll be much better at it. So I think it depends where the tumor is. If you got a lymph node in the neck, the local surgeon would be ideal, because again, that's more tissue. You're going to have an adequate amount of tissue. So I love open biopsies, but they're harder on the person and take longer to heal. But it's a constant problem. It does bring up the very exciting category, though, of they are now can test for tumor cells in the bloodstream and DNA of the tumor in the bloodstream. And you can certainly find some of these mutations in the bloodstream. It's probably been studied more in lung cancer, but what's called a liquid biopsy, where you just draw a tube of blood and send it off. If it's positive, it's very helpful and has saved you a lot of time and effort. If it's negative, a negative doesn't mean negative at all. It just means you don't have it. But clearly over the last year or two and more in the next two, liquid biopsies are going to be maybe a standard of care now. Even data that says if you get your liquid biopsy and it's positive for circulating tumor cells, and you start chemo and then repeat the biopsy, liquid biopsy 2 months later, if the tumor cells are gone, the likelihood that the chemo or anti-estrogen is going to work is much higher. So I think we're just on the cusp of starting to use that technology a lot more. So you can send them more frequently, they come back much more quickly, and they should be less expensive. So that should be at least a part of the future in the years to come.
You know, when I look at it now, doctor, 30 years ago, my surgery was archaic.
Yes.
Everything that they did was so different than what they do now. They didn't even do a sentinel node then.
Oh, yes, yes.
They took all the lymph nodes. I mean, everything was different.
Mm-hmm. Well, it's much more focused, and that's why if they do a sentinel node now and the lymph node is negative, you don't have to do another 20 lymph nodes out. So you tend to think we're not making as progress as much as we could, but then I take a chart from 10 years ago and look at it and just shake my head and said, we don't do this now. So
That's right.
There have been a huge number of advances and at least laying the foundation to be able to move forward with a lot more advances as we begin to understand the target more. We're not putting a whole new engine in the car. We're replacing the one part that's broken,
Exactly.
and that's easier for everybody. And so it just isn't seeming to come as quickly as we want it to, but it's sure coming. Other questions? Anything else I can answer or try to answer?
I know they wanted to hear a little bit about COVID and breast
Okay.
cancer.
COVID and breast cancer. Certainly last February and March, people were seeming to be somewhat running around that the sky was falling. If you had cancer, you were had a very high risk of having major complications. And while that's true sometimes, I've been impressed in the last few months. We've had people with leukemia on chemotherapy get COVID, and they're better in 3 days. So there still seems to be a great deal of heterogeneity in terms of who gets sick and who doesn't. Since we seem to be in this for the long run, at least for the next several months, putting everything off like we did in February and March, we're not doing. And I must say, in general, I'm treating people as if COVID doesn't exist, telling people to certainly be careful, get vaccinated. But at least right as of now, I think many people, even with breast cancer, even on therapy, will do well if they get COVID. There will probably be still a higher complication rate than if you didn't have breast cancer and you didn't have treatment. But the spectrum, somebody who had breast cancer 5 years ago and gets COVID, their immune system is presumably, we don't have good ways to measure somebody's immune system. If you sort of have your breathing test with pulmonary function test, you can say how good the lungs are, or bounce sound waves off the heart and say, how good is my heart? There's no good way we have to, I know of, to say how good am I going to be fighting a virus. So people still need to be cautious, but I think, I don't think we're holding up very many therapies now out of fear of people getting COVID, because it's been with us for a year now, and it's probably going to be with us for another 6 months. So right now I'm telling everybody who has breast cancer to get immunized. It's not a live vaccine. In some groups of people, you may not make as many antibodies as somebody else would without it, but there doesn't appear to be any downside to getting the 2 doses, and so I'm encouraging everybody to get it as quickly as they can. Other questions on COVID? I mean, most of them will be unanswerable, but I'm happy to say I don't know. But we just don't have the
May
understanding.
I ask another one?
Yes.
So I have LGL T cell leukemia. I've had it for 10 years. With an active blood cancer that does affect your immune system. That and COVID too, are as long as it's not a live vaccine, are you saying that it's probably the best route to go?
I believe it is. I don't know of any downside to that. A person with those kinds of blood diseases may well not make as much of an immune response, but I don't know that there's any evidence to say, I mean, with that same disease, I assume you're getting an influenza vaccine every year. You're getting a pneumococcal vaccine every few years. So, or at least should be.
I have it.
Yeah. So as far as I know, and some people are much more cautious, but I don't know that there's data out there to say that you shouldn't take the vaccine. And as I say, since it isn't live, I don't know necessarily what the downside's going to be. The group of people who have autoimmune disease, rheumatoid arthritis, lupus, some of those, scleroderma, theoretically, you might trigger an overactive response there, but so that's been harder to know what to do. But when it's just good old-fashioned cancer, I'm not sure that, since it's not a live vaccine, what the downside is. If it doesn't work, are you any worse off? And you'll still probably make some antibodies, even if you don't make as many as you would have 10 years ago.
Thank you.
All right. Anything else?
You're on mute, Joan.
I have a non-COVID question. I've been given COVID vaccine all day today.
Oh, dear, you're glad to get rid of COVID. All right.
Yeah. I guess I wanted to know, what did now that it's been years and years comparing the Pat's old mastectomy to, wedge resection and lumpectomies and different things. I mean, what does the research say lately? Are we still on the right path with just taking out what we need and leaving the rest, or?
Yeah, I don't think that any of the studies have ever shown that mastectomy is better than lumpectomy and radiation for overall survival. So that I think that's still the right path. What to do with the lymph nodes is still, I mean, we debated this 40 years ago, but if you have a small positive lymph node at the time of sentinel node, do you still have to take all those nodes out? The standard of care is still to do a dissection, though even the surgeons admit that even when they do the dissection, it ain't the dissection of your grandparents.
Right.
But there are some people, since the disease is so much smaller in general in the lymph nodes than it was way back, in a few years, we may not be doing that kind of dissection at all. You take out the positive lymph node, take out the lymph node you feel. Systemic therapy is better, long way to go, so that people aren't getting in trouble with those recurrences in the armpit that used to be horror shows to deal with for years and years. So I think that's one area. But now things are doing so much better. If we give preoperative therapy, of say for inflammatory breast cancer or a large tumor, and we shrink it completely in a way that we never could before, and about half the time we shrink it completely if you're HER2 positive or triple negative, do you still need as much surgery and as much radiation as we used to do in the past? When treatments weren't quite as good, we did all three: radiation, chemo, and surgery. And there are certainly studies now looking at, if you say have a large tumor and do a biopsy after it's been treated and you can't find any cancer, is it okay not to take out the residual and just give radiation? Or if you take out the residual and there's no cancer, do you have to do radiation if you've done good surgery? Those issues are being addressed in randomized trials where people are being studied and seeing, can we get away with less? And that's true in terms of, can we do less chemo in HER2 positive people because we have so much better antibody therapy? So a lot of the therapies now are trying to de-escalate the treatment to get as high a cure rate without putting people through so much as they had to go through in the past. So I think those areas are being studied, but I think lumpectomy and radiation continues to be equal to mastectomy for most people. Some people prefer just having the breast off and being done with it forever, but even both of them. And there's a group that really like just being done. Others obviously are very happy to be able to have the surgery.
Right.
It used to be said that if you had a recurrence in the breast after lumpectomy and radiation, you had to have a mastectomy. And now many times, if it's small and a lumpectomy can be done again, and then some adjuvant anti-estrogen therapy or even chemo, you don't necessarily have to have a mastectomy. So again, more individualization depending on the specifics of the situation.
And you're making that decision with the surgeon and the patient.
Right. And I think depending on if it's mainly a surgical decision, the surgeon and the patient, but we certainly have input too. And that's why the tumor boards are so good that we meet at 6:30 every Thursday morning now, and to have us all in the same room until COVID, and to talk about it. And we now talk online, and some people think it's great. I don't think it's near as good, but it's still better than nothing. But hopefully we'll be all back together by the summer. But it's really more individualization. How old is the person? How many heart attacks or strokes have they had? All those things now go into it. So the one size fits all now doesn't fit anything.
Thanks.
Okay.
Dr. Veeder, I know you touched on immunotherapy.
Yes.
So I'm just wondering, like, in comparison, so of course, I realize different immunotherapy for a different kind of breast cancer. Is there any way for you to do a simple comparison? Like, I feel like lung cancers have more immunotherapies available than breast cancers. Am I wrong? Can you talk about that a little bit?
Yeah, I think the drugs are available, but I think in terms of effectiveness, both for melanoma, I mean, for maybe 7 cancers in the body, there's a lot more indications for immune therapy. The remissions are more complete, they're more frequent, they last much longer. Breast cancer doesn't have that many mutations, and therefore the slow-growing estrogen-positive tumors, the body doesn't seem to get excited and attack them even if we've turned on the immune system. So I would certainly say that breast cancer and colon cancer, interesting, 2 of the most common ones are the ones that aren't responding, but only 4% of colon cancer can be treated with immune therapy. And it's you know, triple negative breast cancer can be treated, and about 20% of those people would qualify. So it is still a very small minority. They're starting to see whether if you combine the immune therapy with other things at the same time, give radiation to kill the cells and expose more targets. They're trying to see what else they can do to jazz up the immunity of the tumor so the tumor is recognized as foreign and is attacked. So some tumors under the microscope will have a lot of white cells around them attacking them, but many breast cancers have very few white cells around them. So I think we're probably, colon and breast cancer are 2 of the least effectively treated tumors with immune therapy now. So I think your sense of that is absolutely correct. That and even when immune therapy is used in the subset, maybe 20% of the 15% who have triple negative, the response rates are better, but they're not home runs where in melanoma and lung cancer, we've got people out at 4 and 5 years and we can't find any cancer, and at least are whispering to ourselves have we actually cured somebody with stage 4 lung cancer. Don't have that seeming to be going on very much yet in breast cancer. So many studies working on it, but the progress in that world of relapsed estrogen positive or triple negative has certainly still been a long toe.
Thank you so much. That's awesome information.
Anything else? Well,
All right, I think
I'm always around. I'm always in the office 6, 7 at night to give me a
Dr.
call
Veeder, we have
anytime.
another question.
Oh, good.
Hi, this is Nancy. I'm here with Karen, and I work at Valley Radiation here at the Cancer Center with Dr. O, and we are owned by U.S. Oncology, and some of our centers across the nation are doing CAR T test, trials, clinical trials. What are your thoughts on CAR T?
Yeah. CAR T and bite cells are all ways of taking lymphocytes and either taking them out of the body and changing the DNA so they're more aggressive and they're more likely to recognize the tumor. Bite cells, BITES, are antibodies where one end attaches to the tumor and the other end attaches to other lymphocytes in a very positive way so that it pulls the lymphocytes toward the tumor and attacks them much more aggressively than even the antibodies we use now. Those treatments have especially been effective and basically started in leukemia, lymphoma, and myeloma and chronic lymphocytic leukemia, the hematologic malignancies. They are certainly starting to be used in solid tumors. There you get to some degree in terms of the quantity of tumor you have throughout the body, how many cells you have, and therefore it isn't been as effective yet in solid tumors. The day may come where you use treatments to shrink down 95% of the tumor cells and then try to finish them off with genetically engineered white cells or the BITE antibodies or something like that. But for solid tumors, the CAR T and all that has not been as active, but it's an example of being able to manipulate the immune system in many ways that we could never have dreamed of even 10 years ago. So it's certainly coming, but it's probably further away for most solid tumors than it is for the hematologic liquid ones.
Thank you.
Okay.
Any other questions for Dr. Veeder? I think he gave us a lot of hope with some of those new therapies and things that are either just coming through or right around the corner. That's to me I've been involved in fighting cancer for quite some time, and to see all those changes and to see how people just continue to survive and thrive due to
Yes.
research is what's so amazing to me. So Dr. Veeder always knows what's coming up the pipeline.
All right. Well, thank you. You all have a good night.
Thank you
Thank
so
you.
much.
Take care,
you.
everyone. Thank you for inviting us.
Thank you.
Thank you,
Bye-bye.
Dr. Veeder. Thank you
most
for all the
welcome.
hope.
You're welcome.
Bye-bye.